This work was about the influence of the conditioning regimens on the microbiota. Just by way of background, we know that antibiotics have a well-established impact on the gut microbiome, but more recently we have learned that also non-antibiotic drugs can impact human commensals. Typically, when we think of conditioning regimens, we classify them by conditioning intensity. So non-myeloablative, reduced intensity conditioning, myeloablative. And we thought that it would be interesting to look at, instead of the impact of conditioning regimens on a degree of cytopenia, which is the typical way to look at intensity, we thought of looking at the actual microbiota injury in transplant recipients. Now, we know that loss of diversity and microbiota injury are associated and potentially drive transplant outcome. So here, our hypothesis was that microbiota injury in allogeneic transplant is dependent on the conditioning regimens. And we studied different patterns of microbiota injury or toxicity in transplant recipients. What we did was take approximately 1,200 patients transplanted, receiving an allogeneic transplant at Memorial Sloan Kettering, parsed them out to their conditioning regimen. We found 8 possible conditioning regimens in this cohort. And we systematically explored the degree of microbiota injury by looking at the diversity of population with each regimen. Interestingly, first we found that indeed myeloablative and reduced intensity conditioning is associated with a more profound diversity reduction compared to non-myeloablative regimen. But we also observed that this effect was independent of antibiotics. As a second stage, we said, well, let's drill down to the regimens and the conditioning intensity groups and look at the regimen. And here we found that overall, there was a correlation between more myeloablative regimens and microbiota injury, but we did see that some of the regimens kind of clustered together. For instance, fludarabine and melphalan was in the same group as fludarabine and busulfan at a myeloablative dose, despite one being the flu-mel, a reduced intensity conditioning, and the other, fludarabine busulfan at a high dose, is a myeloablative conditioning. So this means that the degree of microbiota injury is not only dependent or is not only defined by the conditioning intensity. With that, we actually created an index to rank the different conditioning regimens, toxicities to the microbiome. And this could be used, for instance, in clinical trials and designing interventions. Not only did we discover that microbiota injuries or the diversity is different between the regimens, but we could also observe different patterns of bacteria emerging with each of these regimens. For instance, with the non-myeloablative regimen, fludarabine, cyclophosphamide, and TBI at a dose of 200 centigrade, we found a phenomenon of akkermansia bloom around peri-engraftment. Now, akkermansia is an interesting bacteria because it's a mucin degrading bacteria, which has been found to have both protective effect in inflammatory conditions, but in transplant conditions, we actually observed to have a detrimental effect on GVHD, and we are currently exploring. So that, I would say, are the main findings overall of our study.